You're live.
Hello, loyal fans. Welcome to day 2
to the speakeasy.
Oh yeah. So here's the story.
Here's the story. The story is that yesterday, if you were watching the show, you noticed that there was a constant parade of catering trucks next to us.
Yeah,
Basically,
it was like the superhighway.
Yep. It was hilarious for me watching Melissa, not so funny for Melissa, who, by the way, whose birthday it is today.
Thank you.
And so for her birthday, she convinced someone in catering to give us access to this room out of the way. Lighting is weird. It's all good. We're at the speakeasy.
Yeah. There's a speakeasy in the guts of the Los Angeles Convention Center, and now we know
Who
where
knew?
it is. Yeah. So we have a special guest who has not watched the talk show,
Uh-oh.
so she's in for it. And I just actually forgot Chandra or Chandra. Chandra. Oh my God. Chandra is here, and she's going to tell us some stuff. So please introduce yourself to our loyal fans.
Yeah, happy to. Well, thank you for having me. I'm Chandra Osborn, Chief Experience Officer at AdhereHealth, behavioral scientist by training, psychologist, had a chapter in academic medicine using digital health since 2001 to engage patients in their health. And then in the last 10 years have been bouncing around to different organizations and have the pleasure of being at AdhereHealth.
Awesome. Yeah. So tell us more about the AdhereHealth.
What is it?
I understand you're obviously in the adherence space, but
Yeah.
say more about
I mean, the
what
name
that
gives
actually
it
means.
away. Yeah, so we partner with payers and we support government-sponsored plans. So Medicare, Medicaid, dual eligible members, and we're supporting their medication adherence, working with their prescribers, their pharmacies, and also we're closing gaps in care. So we're helping to support these members getting their, routine tests, screening, clinic exams, and those sorts of things, as well as supporting patient safety. So making sure that they're on the right medications and not, using or abusing medications.
I've heard a bit about this
Yeah.
at the conference.
Oh, yeah?
Just generally the area, and obviously one of the biggest barriers to medication adherence is access in terms of price and availability, right? Like, what does it actually look like for you? And by the way, Chief Experience Officer is one of those titles where it's like, I know what it is, but maybe explain like the
Could be
whole
everything and
patient
nothing.
experience. Like,
Tell us more.
That is true. At AdhereHealth, my role is really to support the customer's experience. So that includes our plans and what that journey for them is like from beginning to end. And also our end users being members, prescribers, pharmacies, and also our clinical team that uses our platform. So ensuring that all those stakeholders are optimally engaged to benefit from what it is that we offer.
but also the end patient consumers, or how's that all included?
I'll include everything all the time.
Yeah, because my background in behavioral science is really around designing for how people think and decide to behave. And so we can infuse that in a lot of different layers.
Yeah. So what is one of the things that you bring in from your background that has like influenced the user flow or the workflow or something that is based on that understanding of behavioral science, if you will? Like what is going to change the way that I interact with your platform or stay on whatever the mission is?
Yeah, so pre-2023, the organization heavily relied on phone calls to connect. Yeah. And since then, we've introduced text messaging. We're launching with digital feeds. We're now communicating with prescribers through the EHR. So we're marrying that, traditional, valuable conversation over the phone with a lot of augmentation. And what we've noticed in our data is that having a recipe that can be personalized to each end user is really what's needed to move the needle. So we've actually seen better engagement by having this omni-channel approach, by using behavioral science, not only in the conversation that we're having with the end user, but also in all of our digital communications too. So everything's accommodated for limited literacy. We infuse ingredients from behavioral science in all those communications, and so we're seeing much greater lift from these different stakeholders that we communicate with.
Are you mostly working with Medicaid, commercial, Medicare?
Medicare, Medicaid, and duals.
Okay.
Yeah.
Awesome. Yeah, makes sense. Makes sense. What are the biggest challenges in the duals population?
Yeah, so in the duals population, there's a lot more barriers to access, to care, to taking your medications. We see more medications, which makes it more complex. There's a lot of social risk factors too at play. So we're dealing with costs, we're dealing with transportation issues, we're dealing with a lot of stress and burden and cognitive load. And so we have to be mindful of that when we're interacting with these members. One of the great approaches that we use is we use motivational interviewing to build trust, rapport, and try to elicit those barriers so that we can support the member and overcome them.
And what is motivational?
So motivational interviewing.
Is what we do we do it to each other?
You might be doing it. You don't. And it's actually a method used to be able to create kind of a safe space where you can talk about what's really hard. And you kind of draw that out of the person you're communicating with. And it's an evidence-based approach. There's a lot of science behind it. It's been really effective in promoting medication adherence.
So what are the biggest challenges you have now in 2026? You know, there's been some changes with the Trump administration to reimbursement, and there's been the Support Act, which allegedly is good. Like, there's all kinds of stuff going on. SAMHSA, we don't know if it still exists. Like, what are the biggest challenges to expansion into space?
Yeah, so the market is, and when I say market, I'm really referring to Medicare, Medicaid. It's very dynamic right now. We're seeing a lot of plans trying to, manage some of the shifting sand. And there's a lot of interest in kind of safe bets. So what we're seeing from payers is that when they're working with a vendor, they really kind of want to go deep in that relationship. How many things can we tackle with this vendor instead of like pulling different vendors in? And so what's been great with our clients is we're actually becoming more entrenched in those relationships. And it's those vendors that are being more strategic and willing to flex and be nimble during this dynamic period are really having that stickiness and longevity with their payer clients.
Makes sense. What kind of outcomes have you all seen? Are you tracking?
Yeah, we're tracking engagement with our communications. We're tracking adherence. We're tracking whether or not they receive the care that they needed. So a lot of claims-based data is what we're looking at. We're also tracking improvement in different STAR measures, HEDIS measures, because that's where plans are focused on.
Okay. Yeah. All right. Cool.
What do you think about some of well, especially on the plan side, obviously, at least on the MA side, there were lots of the rate notice and all that pushes. Like, what does this mean for the kind of peers and we work with? How do they do more with less? Right. Still, these issues probably aren't going away. Right. They still have a bunch of patients, a bunch of beneficiaries, a bunch of members who help.
We're seeing payers talk a lot about using AI and technology, and it's been a big conversation here at the conference with the payers who are speaking, for the plans that are speaking. And we're seeing a lot of that automation and AI to try to reduce costs. So we're getting a lot of questions around that with prospects. We're also, plans are also asking about creative payment models. Like, what can we do to kind of meet their need in a more creative way? And so we're open to those conversations as well. And it gets back to being more of a strategic partner and flexible and sort of seeing what we can work with together. I'll also share that, the success criteria is getting harder. So you need to work with less, but you also need to achieve more. And that's really tough for plans right now.
Well, you've probably also seen that, the government with things like the access model saying, hey, we want you to deliver this care technology versus technology only. It sounds like your model is technology only. So how do you?
You gonna replace them all?
Yeah, how do you? Who are you gonna replace? Slash, who can you not replace with AI?
Yeah.
Or care team?
Well, some of the conversations here at ViVE that I really appreciate is that the plan and Julie Durham from United Health Group yesterday sort of underscored this idea of augmenting the workforce and using AI and software to make things more efficient, but not replacing people, and that you really need to have that IQ, the accuracy of the algorithm, but also the empathy component and the EQ. And I think at AdhereHealth, we're really set up to provide both, because we do have that human element and we do have the technology that we're bringing in to make things better, faster, stronger, but without compromising the empathy and the other pieces that are so key in the populations we serve.
Yeah. We just had a conversation yesterday with Mr. Abe Sutton.
Yep.
CMI, related to some of those low reimbursement rates that they publish for access. And we actually kind of like made fun of some of the plan conversations, like you're just saying, where they were like, oh, no, we're gonna add the AI. And I've never known health plans to be like hyper empathetic. And maybe you've had a different experience. But my guess is that once they see that the AI does the things, they're gonna say, we don't need this entire back room like doing XYZ. Right. So do you think they're full of shit? Those are my words, not yours. Or do you think they're actually going to do plus? They're going to add costs with AI and keep their existing?
Yeah, it's really a great question and remains to be seen. A lot of this is so new in the plan environment. I new as in like the last few months. It's really picking up. So I'm curious to see, also heard Elements speak yesterday about the importance of building AI with the workforce, with the clinical team, and not replacing that team, but really learning how this tool can be used to make what they do more efficient and effective.
Well, the reality is, CMS might, but CMS would have to change their guidelines, and they haven't done that yet. So if you're going to use AI as a payer plan, you have to go to guarantee that they're going to follow those coverage goals to the T. There's no option right now. And again, this could change, right? Like who knows? But like they still have to follow the same coverage rules, and that's a conflict potentially, which might be why we're hearing from payers and plans saying that they are going to sort of enhance or add to
Plus,
replace
ultra, all the things all at once. Yeah, I mean, like not to get too much on the plans, but like they're publicly traded businesses with fiduciary responsibility to the shareholders. So I mean, if I was running a health plan, I'd be like, what? So, but I appreciate what you're saying, and I appreciate that they're at least saying they care about the workforce.
I hope they do. I really
I'm
hope
pro
they do.
business generally, so I'm not mad at
It didn't seem like lip service. It was a theme that kept coming up. So really hoping that there's truth behind it.
Yeah.
So what are you doing here at ViVE, and what is sort of a message that you want to give to our surely millions of loyal fans?
Hundreds.
Yeah.
Hundreds, millions.
I don't even know.
Happy to share that. So at ViVE, getting to meet great people like you. So thank you for having me again. Connecting with colleagues, meeting new people, connecting with our existing clients, learning. I mean, great sessions, great community. Really thrilled to be a part of it.
Awesome. Well, yeah. And well, what final amazing words do you have for our loyal fans?
Yeah, for loyal fans, I would say keep coming back, keep listening to them. They're a lot of fun.
Absolutely.
And also to keep checking out what's going on with AI in the payer space. There's a lot that's starting to happen and to pick up, and it's going to be interesting. And so follow along.
Yes. Awesome. Well, thank you. It's
Thanks for
wonderful to
coming
meet
on
you.
the show.
Thanks for
Yeah,
taking the
nice
risk.
to meet you.
Jumping right in. Yeah.
All right, we're gonna
get this.
change, but take off your badge.
We got
Badges
Mark
are legal.
next. All right.
Thank you.
No badge?
Nice to meet you. Nice to meet you too.
I took the train.
All right. Are we gonna plug in here? Where do you want this? Well, you know, you do whatever you want to do. Whatever, doesn't matter.
That does matter. In fact, it matters. Yes.
Does it matter?
It's probably.
Yeah.
Well,
I think it's closer. Who's the sound guy? Where's your sound
Sound
guy?
guy is
Melissa. Is all right. Yeah, this is why we're
Still good?
so much charm.
Still
Everybody
online?
loves us because of
Okay,
Melissa.
everyone, we just did that quick change and wow.
Okay.
My timing was impeccable. Just hit it by the minute.
Yeah,
My
100%.
internal timing.
Yeah, did you? Oh, I was gonna say,
Nope.
because no one has
Nope.
watched us anymore.
Nope.
We got Mark.
That was my
Ready
internal
computing.
timing.
Hello.
This guy, have you watched the show? Because our last guest did not.
I have.
Okay, so you know what you're doing.
I watched it yesterday.
Oh,
When
oh.
you had, Abe.
Abe.
Abe was on.
Yeah. That was great.
Unfortunately, we didn't know until today that you have to charge the battery for the
What?
camera. So
We thought it was like solar,
We're fine.
you know, energy.
Solar energy. Just like positive
I don't know.
rays.
Like your
Yeah.
aura
Aura,
charges.
Yeah, you know, we usually get away with a lot from vibes.
We
so
do.
It didn't. Yesterday, apparently, it didn't work. But I feel like that was still.
But never fear, folks. Knock on wood again. We found literally Melissa DoorDashed a
Yeah.
battery charger.
Melissa
so
met
it's
the
great.
awesome.
Med City guys
Incredible.
who were doing camera stuff.
Yeah, one thing you can say, Melissa's gonna find.
Melissa's gonna figure it out. Yeah, don't ever steal it from us because this show will go out of business.
Very resourceful. That's
She's
the
very
kind of people
resourceful,
we
and then
like.
we acquired several bottles of wine on the show floor. It's unclear how, and then we
Your
paid
rent
them for their
comes from
services
there.
in wine.
Right.
So yeah, it was great. Anyway,
You
Mark.
guys are feeling good
Hi.
today.
Yeah,
Welcome to
well,
the show.
good is relative. Okay, Mark,
Great.
what do you even do? Like, tell our loyal fans who you are.
Sure.
Yeah.
My name is Mark Taylor. I work with a company called Ready Computing. And we do, our core work is integration. So we've done a lot of HIE. I think you're
Yeah.
aware of the work that we've done
Yeah.
with other companies like Persistent. And then we moved into product, which allows us to be able to create customized workflows. We were trying to do this in the care coordination space first. I came from a health plan background. So I worked in quality for a number of years. And with Ready Computing, we were one of the first health plans to do an integration with our payers and the health plan, to the point where they would get somebody in the emergency room, they would send their entire record to us. We would send everything we had on that patient back to the hospital, right? So if you think about a risk management perspective, they saw every time they were getting out of their network, they saw all the labs, they saw all the pharmacy stuff that we had. So that really tightened that relationship. So when I left the health plan and I went to work for Ready Computing, we were doing that for more organizations, but we thought about how do we emancipate the data that's flowing back and forth. One of the struggles that I really ran into when I was doing this in quality was I still had to have somebody pull us and then to do something with that and then report back manually. So we said, what if we built a tool that can sort of sniff out those ADTs, sniff out the transactions that are coming through. So an example would be, I get discharged from a mental health facility. And a health plan has to get their network to connect with them at 7 and 30 days. Well, by the time you get the claim, it's too late. And now we're getting the ADTs, but now I've got to have a spreadsheet run and somebody's got to work on it. So we created a tool that could grab that, put it into a structured workflow, and then somebody could just work it, right? 3 outreaches, like the whole sort of thing. And then the other part of it was to build it so that it wouldn't be something that needed IT intervention. So I, as a quality director, go in and build my own workflow. I have an initiative. I take me a couple hours. I can build it, just like drag and drop, no big deal, and you can start seeing it. So we thought that was a really clever idea. Then we saw social care coming, whole person care. Like, oh wow, this is a whole new world.
It's a whole thing.
It's a whole new world. So we looked at how do we didn't want to compete with people like us and Find Health and those other organizations that are out there. We wanted to be a place where anybody could go to it, right? So we're working in New York on the 1115 waiver work, which is pretty intense. And Washington State, we're doing some more work out there, and in Georgia, the Georgia Health. And they're all different, right? So when you think about whole person care, every state's different. Every state's approach to whole person care runs very different. So you have to have a tool that's adaptable and helps you innovate. And we thought this was a great idea to kind of shift into that space. And we've gotten a tremendous amount of success doing this. We're supporting substance use disorder programs. preventing deaths. I mean, at the end of the day, when we look at this thing that's coming out of the program, we prevented people from overdosing. And that's just like very satisfying.
Yeah. Like, how are you actually preventing people from overdose? Like, walk me through that.
Sure. So like we're the more of the how than the what.
Okay.
So we worked with our friends at the Staten Island, and they had gotten some funding and figured out a program that could do harm reduction, get people connected to MAT treatment, right? So the idea was to try to help them, and they brought together the hospital networking area. They brought together the justice system. They've also brought in us to do the technology and people to do actual outreach. So there was a list of people they had.
Right.
Analytics group came up with an algorithm defined by to figure out who was at the highest risk. Then they found out where they last existed, and then had those organizations intervene and reach out. So really
So
powerful.
you think any kind of, care protocol or clinical protocol, you can then adapt to.
That's right.
Right, so if somebody has the clinical protocols for a certain disease state, whatever it is, you like, bring them, need to have.
Yeah, and there are organizations that do clinical protocols
Sure.
really well.
Sure.
We're not trying to step into
Yeah.
that space, right? I know we're here organizations, but But-
I just more the how.
yeah, or the
But more like pointing to those established.
Right.
Yeah.
right.
Yeah.
And then when it got into the 1115 waiver stuff in New York, I don't know if you've seen the contract that came out from New York State, but if you've ever worked in Medicaid and you saw a model contract and it's like hundreds and hundreds of pages, I couldn't see how a community-based organization could even
Yeah, like,
start
no
to
problem, let
digest
me bring in my high-priced attorney to
Yeah.
review this contract.
Right,
Yeah.
right. So they were smart in New York State. They brought together, they put everybody under the social care net.
Yeah.
concept.
Mhm.
So they took care of all that administrative stuff. And we were the software to take care of it for one of the.
Okay,
regions.
okay.
No, I mean, that makes it so, you're totally right.
Yeah.
It's so unrealistic. Like, oh yeah, these social care, like, providers, they can, or, organizations, they can bill Medicaid. You're like, oh, it's so easy.
Yeah.
It's like totally
The
chill.
billing is
Yeah.
vital for
Great.
the people, right?
Yeah.
Thank God we have background. in
You're like
billing
a
because-
food bank.
Right.
You're like a community, like a church food bank. You're like, okay, let me fill out the 900-page
Yeah.
application to bill Medicaid.
Right, or like what form, what code do I use for
Right.
this? Like trying to sort through that, like.
Do I have to pay AMA for this code?
So let's abstract that from the people that are doing the work.
Yeah.
We figured that out at the back end. And all they basically go and it says I gave them the meals. And it was this much is how much it
Yeah.
costs.
And then
Take
and
care
then
of
you do.
everything else.
That is awesome.
Yeah.
Because we talk a lot
So
about
that's
like
important.
friction
That's really
points, right? Like, okay, like great, we have all these great ideas. Like, yeah, let's get the churches and food banks to like bill Medicaid.
Bill Medicaid.
Yeah, and then but then there's like that is like people think, oh yeah, we've closed the gap, but it's like the
No.
actual doing of the thing. So that's pretty awesome.
And nobody wants to pay any, I understand, like, I get that, like, profits in general, they're like a tricky world, there's all kinds of different nonprofits, but like, nobody, trust me, no grant wants to pay for the administrative work to bill
Absolutely.
with something, like,
Right.
none of that is funded.
Yeah, uncool.
And it sets us up for the future too, right? So this whole person care grows, right? And I mean, it's the beginning, I think, of
Yeah.
whole person care.
Yeah.
In Georgia, we were able to swap out their HIE platform and tack on the CIE platform with our
Oh,
channels.
that's great. That's
You're
great.
the platform for everything in Georgia. For the
Yes.
for the GHIN?
Yes.
Okay.
Yeah.
But are you integrating other types of, you're integrating up with other folks, you said you're not replacing Unitas or Find Help, whatever.
Correct.
Yeah.
Right. So
Could you?
the Unite Us Find Help, no, because we don't,
It's
they're
a
very
lot of work to
specialized.
build up that.
So that's how you why,
that-
right? They're really good at
Yeah.
going out in the community,
Yeah.
signing up those community.
Yeah.
Right.
Tools and getting people in the community to use it. These are easy.
Yeah.
Now take that and abstract that. And now if I'm at a state level or HIE or CIE level, I'm not just going to use one. And I may have people, I might not want to use one of the two that exist, or I would use them both.
Right.
And I have a third. Or I have,
You've got some
adopt-
local thing.
I have this person that's like, I'm not going to sign with them. I want to go direct. So we try to meet them wherever they are.
Yeah.
And thinking
That's
about
so interesting.
the network of networks idea. We want to be the fabric of the chain,
Sure.
Yeah.
you know, and not to try, again, it's not encroaching on other organizations, right?
Who are your competitors?
I like to think we stand by ourselves.
Oh, okay. Nice pivot. Nice pivot. No, because like this is actually like pretty useful.
Yeah,
Are you, so do you have like tons of business going on? Like,
we have a lot of interest and a lot of people we're talking to.
eh,
You know, as the states are starting to roll out, Colorado, launching again, trying to break California. California's a really tough state to get into.
Well, California has manages public health and Medicaid at the county level. There's a lot of counties, and only some of
Like
them
this
are big
one.
enough to be able to afford
Yeah.
the appropriate technology. So obviously, Innovator has something in a similar space, probably not the exact same thing as you guys do, but yeah, finding a buyer or getting the state to sort of sponsor the whole thing. That's not very common.
We've gone on a lot of dates in California.
Yeah.
You know, nobody's put a ring.
A lot of dates.
yeah,
A lot of dates.
yeah,
Tell me about it.
There's been a lot of situations here. Maybe you'll get a whale like LA County, which is bigger than most states.
Yeah, we also try to remind people that our counties in
LA
California
County's 10 million
are
people.
much bigger than a lot of the states out there.
Yeah.
So we're not hackers. But coordination at state level is also it just needs to happen as well.
It's also good to understand that it's like there's no island that can do science,
Yeah.
right? We've talked a lot to people, lots of different companies, and look, people, technology companies, providers of the services, they need to work together to figure out how to come together. It's not going to happen in a silo.
Yeah.
We're going to hit that.
Mhm.
Look at community engagement. Right? The workforce requirements. If I'm a state, I'm kind of going.
Well, I'm usually like blacks out and forget that that's what they really see.
Right.
I also love the rebrand, community engagement requirements.
Yeah.
Love
That
it.
gets very
Love
confusing. So when you say
it.
it, they're like, oh, like going to.
Oh, that's
Blue
nice.
Mountain.
That's nice. Is that like a big grant program?
Yes.
Work requirements.
But to your point, there's a massive need for this kind of stuff. There aren't enough people doing it in any way, shape, or form, right? There's a huge gap, like that being that sort of data fabric. Just is not enough.
Right.
Yeah.
And it's needed everywhere. Like any state who is realistically like looking down and saying like, ugh, like look at that ticking time bomb here.
Right.
Like
Yeah.
there's so much you have to do, and you need that data.
Well, gosh, the state is sitting there going, all right, so I'm in a mid-cycle too from politically. So now how much am I going to invest between
Right.
now and the end of the year?
What's my calculus?
Yeah.
Right.
How do I get reelected?
What has the biggest potential impact, right?
Yeah.
For
How can I get my private jet out?
Yeah.
Right.
Well, so a question for you about that elections and the administration and all that. So like a lot of, obviously Medicaid funding took a hit. SUD funding has taken a hit. Well, allegedly, they took it away,
We don't
gave it back. We don't actually know what shit that is.
Confusion is part of it.
Yeah, and then there was a big no go on anything that was using words from the Biden administration. So did that
Right.
affect your business in the States?
Not really.
Ah.
I think, I hate to say this, and it's going to be on recording, but I think there's a public rhetoric that's happening.
No one watches our show. Don't worry, that's fine.
There's a public rhetoric that happens in front, and then there's the real work that happens behind the scenes.
Yeah.
Like we know that CMS and HHS, they're looking for success stories in this space
They are.
specifically. Look at how Dr. Oz put the call to pledge out, right? Dr. Oz and Relman.
Yeah.
They put the hey, pledge to help us do community engagement. We're on the GSA. So we put in our pledge. We're on the list now. These other big players, which are really excited about, by the way.
Nice.
But we have now an opportunity to provide some of that gap. So the state may want something that's small, gets them over the hump, and then figures it out in the future. But we can bridge that gap.
Yeah.
Or we can work with other organizations
Yeah.
to bridge that gap. Because now they've got to connect people they've never connected before.
Yeah.
They've got to connect CBOs. Again, the same problem with like the payers paying, getting claims out of the CBO. Now they're like, how do I report workforce requirement hours? Right? How do I do
How
that?
do we do that?
So
Yeah.
how do you do that and make it easy?
What do you think about the discounts that those people on that list provided to the federal government?
Right. Well, did you see the word free too? They said free or discounted service.
Which one is it?
Yeah.
Right. Yeah, exactly.
Yeah.
Exactly.
Also, I'm pretty sure, what was it? Like they offered 600 million.
It was
And-
like
And I was like, that's like half
sounds
of
like
one
a lot.
Deloitte contract.
I wish I had $600 million, but that is nothing.
I make fun of
Comes
Deloitte.
to-
When I say Deloitte, I mean every prime contract.
Yeah.
Basically,
you
you guys are just scalping America.
Oh,
Everyone stop.
Cat's opinion. Nobody else is saying this.
Stop now.
This is
Anyway,
a cat
are you free or
opinion.
discounted? What's going on here?
We're discounted.
Okay,
Discounted.
discounted.
Still,
Are you free or discounted? Well,
And, to. I don't provide free services.
So,
Yeah.
I mean, they have the money for it too, so let's not forget. They have some
Yeah,
money.
big disparity there
Yeah.
between different types.
Well,
of
think about free.
providers.
Free is going to be, they're going to put it in for free and then they're going to up their cost on their licensing fee.
That's for
Right, I mean, that's just going to happen.
Oh, well, this was like actually super interesting. I learned something. So
Wow.
thank you. I don't always learn something.
Well, okay. Glad I was educational and informative.
I love it. Yeah. Super, super useful for the States. What would you like to leave our loyal fans?
Final words for the millions of loyal fans.
Whole person care is not going away, regardless of what we hear from the government. Work together, bring everybody together, and it's going to change. It's the thing that's going to revolutionize healthcare.
Ah,
It's absolutely 100%.
Nice.
awesome. God bless America.
Very good.
Thank you,
Great.
guys.
Well done.
I appreciate
I
it.
love it.
And we'll see.
Call us.
Am I out?
Yeah.
Oh,
Very good.
all right.
Switch. Hand the mic off.
Yeah.
Sorry.
Oh my gosh,
Thank
we got
you,
this
guys.
guy coming on.
All right.
Okay, I don't know where you want to put this.
Thank you.
Pocket. Just get it.
Enjoy your
Nice.
He's good. Yeah. Welcome, Mario. Oh my
No,
gosh. So, loyal fans.
thank you for having me.
Yeah, we're gonna make you introduce yourself. Well, introduce yourself and then we'll tell a story about the eating dish.
Okay, so
Millions of fans.
do I direct my gaze towards the
You-
camera?
you
certainly can.
You can do whatever you
want.
Look at them. They want to see your face.
Hi, millions of fans.
Yeah.
Uh,
Please.
my name is Mario Danek. I'm CEO of Qnovia. What's next?
What's next is, so I met Mario on the internet with a mutual friend, Raman Bastani, who's the CEO of Kalpana. And I don't actually remember why we were talking. Usually when Raman says I have to take a call, I do. And then I think you were like, do you know how many people smoking still kills? And it was like very passionate. And well, tell our loyal
A
fans,
lot.
what are the stats? Because like
I
that's,
just know a lot.
I mean,
Yes.
not like in America, we're like, no one smokes anymore.
But literally saw a bunch of
No,
stuff
I mean-
today.
Well, let me give you the numbers.
Yes, please tell us more.
You know, we're talking about 30 million Americans who still smoke. 70% fly in our, our cost burden annually is $600 billion, so just over 2% GDP. Over 10 years, the way the government likes to frame it, we're talking $6 trillion of aggregate
Wow.
cost burdens.
Wow.
So it's pretty, and look, I mean, I know we're gonna have a lot of fun today, but I think it goes back to what you said in the first 5 seconds of the show, which is this is globally, not just US, like half the world thinks the problem's in software.
Yeah.
And the other half of the world thinks the problem's way too big to solve.
Yeah.
But somewhere, I think that the vertices where they intersect, the innovation is going to be the key driver that's going to change this. It is the largest cause of preventable death disease worldwide still. So we aim to
When you say smoking, do you mean smoking combustible cigarettes or do you mean everything tobacco? This is like nicotine,
mainly, so
vaping,
of
whatever.
of that statistic, 90% of it stems
It's
from
smoking.
legacy combustible cigarettes.
Yeah.
Yeah.
And then the other stuff is like oral tobacco products and
Yeah.
stuff like that.
Which are cool looking here.
Yes,
Super cool.
Look, I think there's been a lot of, people are surprised that I'm not like super into big tobacco. I think we all know what they've done in the past. We need to litigate that. I think my issue actually is with pharma because they've done innovation, right? Because to your point, why is sin? Why e-vapor products cool these days? Well, the bad boys that started this stuff are the only ones that e-vapor in space.
Mhm.
Pharma kind of done it.
Yeah.
And so, look, I mean, what we did is we created a combination drug device product that emulates what we think are going to be successful attributes that we've seen in the consumer recreational space, like a cartridge pod interface, ultra portable, and surprise, actually available. So you get that pharmacokinetic curve, tells you drugs in your system. Historically, that's probably why a lot of the legacy predicate NFTs, like gum lozenges, patches, takes
It's
so
a
long.
different mechanism of delivery
Yeah.
and it doesn't feel the same.
It's both. In addiction medicine, oral sensory cues, behaviors, hand and mouth fixation matters, number one, right? But more importantly, than that actually is the speed, the pharmacokinetic profile,
Wow.
right? So when you look at, I'm not going to call it brands, you look at like guns or transdermal patches, it takes 30 to 60 minutes for that individual
Wow.
to realize things in their system.
I'm okay. Like
Cigarettes,
soft or
6
whatever.
minutes, you get max
Wow.
saturation, 6 minutes. Our product just completed a clinical trial.
Wow.
closer to 7 minutes. So that window is exponentially truncated.
Yeah.
So our aim is to prevent relapse. Our aim is to prevent the withdrawal of your life, and then gradually titrate down the 12-week course of treatment, and hopefully you stop using your device and the cancer sticks are filling.
Yeah.
That's the goal.
So we talk a lot about regulation, our great regulators, right? And how they, I know, and how they can both like encourage innovation in the market and just like crush it. So why is there no innovation in the smoking cessation space?
Well, thank you for putting me on the spot while we're doing review.
I mean, you can,
Nice.
you can just come, you can tell us we're
No,
ready.
no, I
We'll move on.
I will attempt a salient position on this one while maintaining.
Great arms like.
Right.
Yeah.
Exactly. Thank you for that. I was searching for the words. Yeah, listen, I think
Should be fast.
I will highlight regulatory authority here, MHRA, UK. So that's the UK's part of the FDA. They have a pathway to bring novel nicotine products to market as therapeutics that are exponentially quicker and in line with the current government consensus of all scientific bodies relative to health and safety, right? The FDA still, despite some really cool announcements as of late, it's kind of languishing in some of that bureaucratic, backfiring sort of landscape.
Yeah.
And the guidance isn't quite clear. It is in alignment with what we're seeing overseas, for instance, right? So it looks like part of that is, the FDA is always been the gold standard for a reason. But I think we need to take a very sort of clear approach towards specific indication areas, because the safety profile of nicotine replacement therapy, where the API is nicotine, is probably the largest molecule of the planet next to oxygen. Not the same as a cutting edge, brand new process like or some sort of gene editing technology where we need to do much more of the safety of standpoints. So I'll leave it at that. So
No,
there's room to improve it.
I get your point
Very
though.
costly.
Yeah, I get your point though, right? We're not, there's the novel part of what you're doing is the delivery mechanism. Primarily, right? There's no effect, but it's not a total de novo. That's a term of art. It's not a totally new thing that like is not understood.
It's the route of administration.
Yeah.
So we actually received first.
See, that's really innovative. When you like don't have to like develop a new compound or something. So you're like, hey, stick there. You have what we did.
Yeah.
It's like actually help people out.
Yeah. I mean, no, we always talk about that. Like innovation can sometimes being something, doing something that's better.
Or a different way.
Yeah.
Totally different way.
Yeah.
Interesting. Have you so like been following obviously too much the CMS access model? Obviously did not, but smoking cessation as one of the outcomes and one of the programs for this time. But they did say, they said to us yesterday, said they would be considering adding new disease states or new outcome focus. Have you talked to them about smoking cessation as potentially being part of it?
Not through official channels, but we're meeting them shortly. Actually, I mean, I think it's
Please do that. Gabe, this is a good idea.
Yeah, I mean, it's a total travesty from a policy perspective.
Yeah.
It's an easy win, Maha,
Yep,
by the way.
There you go.
It's from a cost. I mean, listen.
Who can
You were-
argue against like smoking
Well, it's-
cessation as like a health exercise?
Yeah, well, you
It's also, you should also
it's
be
slow,
better.
right? It's a slow kill.
Yeah.
That's like one of the problems.
It's also
One
kind
of
of
the
the greatest return on ROI.
Yeah.
From a national investment perspective. So, no, it's I'll speak to that.
Nice. I was thinking of it as well because of course part of the access model is the tempo pilot through FDA.
Yeah.
So it feels like a bummer to miss out on the opportunity for moving these forward faster. It feels like it would fall right under that category. So very interesting.
What's super interesting though about this generally is like, right, like no one feels like it's a problem. So one example, similar-ish, right? Another thing that kills a lot of people, alcohol, right? With the Heroes model, which has that's been canceled. Well, no, but like it's we're both fine over it. That's just in case no one can tell. As is Melissa. But whatever. So this may be a thing for us too, but no, in the Heroes program, which was in our PAGE program that was canceled by the Trump administration this summer, they had 4 areas that communities over 500,000, you could do address and improve outcomes at a broad level. One of them is AUD. They actually received no, I believe it was no applications.
It's incredible. It was actually incredible.
It was maternal health, CBD, and then OUD.
I think we're all.
OUD and AUD
The
was,
entire country, not a single
they're
application.
like,
for
we're not,
OUD.
we don't want to do that.
Yeah.
It's not a problem.
But
Yeah,
yeah,
yeah.
so I guess it's, I'm assuming there's some similarity there. Like, yeah, smoking's like it kills you after a long time.
Right.
Like,
Yeah.
you know, we have all these campaigns and programs. Not a lot of young people smoke anymore, but 30 million people is wow.
It's a lot. Yeah.
Yeah.
And it's something that rears its head later on. So, right, it's not something that acutely impacts someone tomorrow, certainly. But you become addicted to the engagement, and then we can, as a nation, you can literally track like loss of activity.
Yeah.
We can
Yeah.
at state, almost actually at a municipal level, we can track that disease burden, cost burden,
Yeah.
hospitalizations, impact. I mean, the second largest cause of cardiovascular disease is smoking. So
Wow.
there's crossover effects.
Wow.
It's
Well,
it's
also-
the elephant in the room. I mean,
Yeah.
to pontificate a little bit.
Sure.
If we solve this, we might have the largest impact of public health ever.
Oh, for sure. If you,
Right?
if you,
If there's crossovers.
That's awesome.
if you want to target, if you're like, what is the one thing I can do to target the average life expectancy of the group? That's your measure of success for like health of a country or whatever.
Right.
That's what you should put your money, your next dollar into.
Right.
100%, because you would get like return on that number much faster than a lot of other things.
Yeah.
For sure.
Absolutely.
I mean, I think just like alcohol use disorder and alcohol use generally, there are also a lot of secondary community and family and child effects of smoking,
Yes.
right?
Yes.
I think like in particular, like you mentioned that there are side effects that lead to cardiovascular disease in a person who's a smoker, but asthma, child health outcomes, like very directly affected by smoking.
Yep.
Parent,
Yep.
very directly affected.
So one of the other things you mentioned to me earlier this week, is we were talking about AI, and you actually have something going in that space as well. So related to the
Yes.
access model tempo, you also
Yeah.
have like
No,
the
that's-
only topic anyone's talking about in this space.
Right. I mean, it's a little more recent relative to what we are on the drug development device side. But listen, what we're looking to build is a behavioral health coach, a behavioral health tool, if you will, that works synergistically with the brain. So historically, when you look at smoking cessation, we had that issue of legacy sort of failing or just not really effective tools that meet smokers where they actually are. We are going to create a breakthrough to that. But then you've had sometimes very good apps, very good behavioral health modulations. It just means like vacuum in a silo, not connected to therapy. And so our thesis is if I can couple a breakthrough therapy with starting off the generative AI, eventually they get potentially a clinically validated agentic AI that acts as a 24/7 accessible, 24/7 accessible clinical therapist that can help you wean yourself off your addiction. So like moments where a lot of it's cute. You have your morning coffee at 7 a.m. You're starting to feel that because of the ritual, you want to grab a cigarette. Well, your delivered dose topography, all your biofeedback loops are being recorded live and transmitted to the data set, which houses it in the app, the way the device's Bluetooth functionality communicates. So it can tell you, hey, don't grab your cigarette, take a dose of the respirator. So communicating in a humanistic way to actually walk off this and be accessible. The other thing is, we talk about access, we talk about health times too. It's the bleak reality with smoking in particular, not other devices, smoking in particular, 60% of the people that smoke are in the United States have lower socioeconomic status, and 70% of them have co-occurring mental health disorders, whether it's anxiety, addiction, depression, etc. So I put myself in someone's shoes who's a single mom, 2 kids.
Yeah.
She's lucky enough to have healthcare coverage. She doesn't have the luxury to go out there, source a therapist to help her with her problem.
Yeah.
We have a breakthrough therapy and a therapist that's available 24/7. I think will create adherence on this wristband. So that's the thesis. That's the one. We're gonna go.
Oh, don't worry about it. We have one more question.
Yeah.
What would you like to tell a little bit?
listen to these women.
We're the best.
Absolutely.
Listen, why are we going
These are the types of discussions. Things like AUD.
Yeah.
National spheres, so.
Thank you. Thanks for
Listen, all right. Next guest is up.
Yeah. Our last guest. Yes. She's not yet.
Well, come on, show for real.
How do we do that?
Well,
Oh, so here's the problem. Hey, what's up? Hold on 1 second. So that was good. Amy Gleason was going to come on the show, and then I guess we were going to put her on.
yeah, but then.
Abe brought Ida, his chief of staff. So new friend, and then we only have 4 mics, and then Amy walked out. She's mad at us.
We're gonna.
Well, wait, you know what? And we'll send her. That's good. Well, can't she? If it's under $20 or something like that. Hello, welcome to the show. You are our last and final guest, maybe. Oh my goodness. Yeah. So you are repping both Manatt and.
I think mainly myself.
Oh, fantastic.
Oh,
Well,
but,
introduce yourself. So you're
Yes,
In
absolutely.
whatever way you.
No,
like.
yeah, I mean,
Sure.
you're on LSD, whatever.
I'm something Gupta, just yeah. I was
Yeah. We were just talking about that. Pulmonologists, we
both.
got- No, who's
Two
smoke
sensations.
Oh.
What do you think?
Oh, that's actually very
Yes, I was like, hey, almost like most of it.
Yes, we got our data.
She's like, excuse me.
So clinically active pulmonologist. Couples patient was alternative. That's prior to now.
Yeah.
Just being able to look at that, right? Directors and organizations, parents, back control.
There you go. See?
It's really important. But I love operating in the space of that's like air technology.
Yeah.
So how'd you find us?
I
Because
think
you're
we
like
get
pretty credentialed.
We're.
Who's
Remember? It was a whole conversation. It's like it went in one ear.
No. Anyway.
Yeah, it's to the extent that I'm in
You might want to explain what it is. I don't know. I'm not sure.
for sure.
It's in California, so she's probably
No,
like,
the Phoenix. The Phoenix. I know the Phoenix.
Phoenix.
Look,
I feel
Susan.
I feel like you normally are just like
Susan's
California.
Phoenix. No, I don't think Susan Menard is Phoenix.
That's right. That's right.
Yeah, Susan's our girl.
Okay. So yes, yeah.
She didn't get to come out. Because
Tell
it's
her
hard.
millions of women.
Yeah, but yeah, I just didn't explain it. So.
No, so yeah, I'll do this. Yes, so big ally of the California Health and some administration. And I got on this for months. And it's still evolving. The thought here is Phoenix, which I don't know what the entire acronym stands for here, but it's the Public Health Data Exchange.
Yeah.
And it's a state-based data exchange for public health purposes. And in effect, it's trying to make California a surrogate for what the CDC should be doing for 50 states. But California is not going to, at the state level, start to share information on, say, we're in the middle of flu season, flu strains.
Yeah.
What's happening? What are we seeing? RSV, COVID, all the
Yeah.
usual things that CDC should have their pulse on. Now they no longer, because that actual office has been significantly gutted. At the state level, California is now saying we're going to create this agency, this exchange where they're sharing strain information across their ports, across the entire state with other nation states. So it's a subnational approach to global health data exchange.
Yeah.
To hopefully make us smarter, because we're going to be developing the vaccine for 2026 into 2027 soon. And global authorities are going to need some data from the United States. So that's what California is aiming to do, is step into that breach. But you actually note that it's not a standalone approach in California.
Yeah.
Phoenix, this state exchange for here in California is the biggest state with 34 million citizens.
right here.
That's what we hear.
That's what I.
Yeah.
But,
Bigger than
Bigger
Canada.
than most countries.
Yeah.
yeah, I would say it's sort of a blue-purple state coalition that's forming, and so
Blue, purple. Nothing close to red.
not yet. And so we have some key gaps here, which is, but I would say this is suboptimal.
It's going to
but
be multi-state.
it's been multi-state.
Well, okay, so Susan's told us about the fees. Okay, I probably just-
She's the head of it.
Yeah, she's awesome. And then Deb is there as well, right? Yeah, and then I think, were you all speaking today or?
No, so I was
Caitlin
not,
Gentleman?
but Caitlin was,
Yeah.
and they were all speaking. Caitlin's, head of neuroepidemiology.
Yeah.
Just like distilling information.
Yeah, very cool. And she's working with our girl Ink on Popeye.
Yes.
Yeah,
She's
yeah.
on many things. She's doing an interesting project called Project Stethoscope as well in California, where she's helping clinicians like myself understand best kind of issues, like for example, attacks.
Sure.
There is whether the first time I heard this, I don't know if you want to call it conspiracy theory or myth or disinformation, whatever it is, but there's 20 to 30% of the country believes in the motif that you can get hepatitis B. You're a baby only through sexual intercourse or some sort of sexual interaction, and clearly not true.
Yeah.
How do you break that down? And I would say medical school doesn't teach medical school, nursing school, physician assistant school. None of these entities have time, frankly. I mean, and maybe that's not a good excuse to be teaching skills on how to be content with falsehood.
Right.
And so that's
Right.
what she's trying to do here. And
That's awesome.
Well, I mean, I am, you may not know this, but I am one of the more pro-vaccine people around. Love vaccines, super big fan of them.
She wants
I want them all. I love
All of them.
I think they're great. But I also, I also understand that people have questions, don't necessarily get good sources. They didn't the answer on vaccine because it isn't, believe me, I'm a doctor, right?
Oh,
Now,
no.
but at the same time, like, no one is pretending that you have all the time in the world to like go through every single possible question, bring up more, go through research with every single individual patient. So it is a challenge, right?
Yeah.
To quote my friend Erica, was it constructive curiosity? Got it.
Yeah.
Yep. Just right over there. You can't see her. I think but again, you need time, you need resources, you need probably like motivational.
Well, it's like applied behavioral science. Like it's not something that you just get born into.
100%. I mean, my wife's a pediatrician, and we talk about the 15 visit as being sacred because they don't have more than 15 minutes. And, I was having this conversation with someone earlier. We're about to say the union, right? I hear not a lot. Sure, we're going to hear about a longer list.
We're going to hear about a lot.
achievements.
We are.
And,
I just,
and I do think to give credit where credit's due, there's been some excellent progress on digital health innovation, making it easier. I came from a medical device background.
got the first trial. I don't know about that.
Next thought.
But
Allegedly, just to be told.
Yeah, sorry. Keep
Sorry.
going.
no. But
That's
we're
not really
so
that's
we're
being
touching on
nice.
everything. But I like super innovators to create devices for that.
Yes.
Burn some regulations.
We were just talking about accidents. Yeah.
But this, but it does not excuse saying, you know what, that needs to be shared. I think the good is good, but it does not mean bad. I think we made a lot more physicians the job for other healthcare practitioners.
And it's one thing to be like, oh, you should get your measles vaccine, but you need kind of a continuous sort of approach to that because we have major, crazy hotspots that are like so dangerous.
We do.
To give up having eliminated disease in your country just in a few.
Cost of doing business.
That's
That guy's out.
that's really
That guy got
Yesterday.
that guy.
That guy's out
Yeah.
yesterday. Yeah.
I'm assuming he just walked right out.
I mean, I'm glad to see Chris Coffins in a position.
God bless Chris Klopp.
Yeah.
We love that guy.
yeah, dude.
Yeah.
That guy. I think that guy's gonna ask you to get your vaccine.
Yeah.
I think
Listen,
he is.
probably. I'm vaccinated, Lisa. I know it's hard to
Yeah,
get.
yeah. A couple times in your life, you gotta get a booster on.
Chris wants to get the measles vaccine. I'm like, I'll probably do it.
Chris is a pragmatist. He knows, I mean, this is not many minutes, but 20% of children's hospitals have since 2008. We've lost 20% in raw usage.
Yeah.
They're not transition to adult ICU beds.
Yeah.
On a way entirely.
As some people who are teachers to tell us, children are not just tiny adults.
They are not just healthy adults. They
Yeah,
need
yeah,
expertise.
we hear that often.
Yeah, we don't
Yeah.
attack the system. So I think this looks at that the same way we do.
Yeah. Yeah, we're big fans of Chris. He was my old boss. And He's a fan of the show.
Fan of the show.
Obviously. Yeah. So,
Okay, okay, good.
So hey, Chris, what's up?
Yeah.
And okay, California. Because I actually do often ignore California for a real reason, not just because it's on the good jealous. One, you tell me everything I need to know.
Where are you?
Two, I'm in Georgia.
I
Two, California is so big, and they like California operates like another country, truly.
Yeah.
So for me, it's like I'm like, well, I can, and I have a lobbyist in California for my own company because it's so different, right? Like it's so. I appreciate that California is trying to basically take over America. Like I'm here for that. Like I kind of love the vibe. Like I think Newsom's like, Trump said this, I'll do that. Like I'm into it. Like I love it, and also I think it's good, right? And it's a huge chunk of the country. It's 10% of the country, right?
Yeah, that's,
Um,
I think more.
So two questions.
Okay,
One is
Matt.
legit, and one you can take however you want. The first is whatever happened with BXF. We had the
What's that
BXF
stand- what's
the
that
data
stand for?
exchange
And I'm going to the conference in early
so
March.
it's still around.
now.
Okay, so the Phoenix is happening, which is cool. I'm here for it. Love it.
The BXF is a public health exchange.
No, but also it could accommodate. Why do we have all? Maybe why do we have two separate exchanges?
Maybe it will. I will tell you what they say.
Yeah, be like, why do we have the
I
Phoenix?
don't know why.
Why are we doing that?
Sacramento, the Data Exchange Framework Summit, with Connecting for Better
He
Health.
didn't even know what it was. My next question is, are you
I didn't know
so
that.
when we have president meeting, are you going to be the secretary? Because you kind of have to buy.
Oh,
I mean,
This is a great first
that's
campaign
it.
for you.
I don't know.
It's very- You heard it first.
I don't know if that's a compliment. Given, but
They just go for it. Go for it.
you will be a massive upgrade.
I
You're a real medical upgrade.
You're like a doctor.
Fantastic.
Yeah.
In.
Yeah.
I mean, no, I
You know,
was told.
Pooja.
I know Pooja. Yeah,
Let's look
representing
into this
myself.
later.
Yeah, representing myself. It's like,
Yeah, representing yourself.
I would
Private
say,
citizen.
Running.
Just let him talk. Now we gotta stop. Okay, let's go.
I mean, listen, seriously, in all seriousness, I don't know who the president's going to be. I think if we're talking, let's have that conversation. I think I like what Newsom's doing. Admire it. And that's some flaws, just like yesterday.
Yeah.
But that notwithstanding, I mean, I hate to say that he's right, that people want strong, weak, right. That's the world that we live in. And
I would say yes.
I don't think a guy from California gets elected nationally, but what do
I don't know. Yeah, I mean,
We also didn't think Trump was gonna get elected twice.
Yeah.
So, I think it happened.
that's right. But no, I mean, I spend a lot of my time. I would say it's nice to talk. Once you care my clinical life, people can focus. I'd say 40% of people are dying when they go to this. 40%.
Wow.
And they maybe on average spend 2 to 3 weeks of their end of their life dying in an ICU. It's really sad. And we think about American healthcare now, about 30% of those healthcare dollars in the last 6 weeks of life.
Mm.
So at the end of the day, how do you play on kids? That's what all of us in the ICU are thinking about. It's not, well, let's throw the kitchen sink. Anybody should throw the kitchen sink.
Yeah.
It's good. Keep it out there in the first place. That's I think better trusted health communication, better at top your services, getting vaccinated, as you should be doing. But obviously, we're in a place right now where there's no trusted institution.
Yeah.
There's few trusted voices.
Yeah.
And so being able to have a on the bedside, yeah, love to do it. So, I think communication is a vital one. I do wonder, I sort of straddle the world between legacy broadcast and digital media. It doesn't feel like traditional flows of information. There's new listen. Even with Locken,
The guy's the best.
he's the best. But I love what they're doing that. They're experimenting. The pit. I love the experimentation, but there is not at a medical school. I don't think academia and health systems fully embrace the world.
Well, there was one health system that not a lot of health systems invested in their whole broadcast thing, and everyone ragged on them for it.
Nice.
One of their-
NYU.
Was it NYU?
I just did it.
It was this thing, the Super Bowl, but there was also the whole thing about this non-profit health system was best in
Was
this
it
whole
like it.
broadcast thing. And I was actually,
Yeah,
a terrible
that's what-
idea.
Yeah, terrible.
Yeah. I mean, I get it. I get it. Makes facility films. I can understand the criticism, but investing in health is not about.
Yeah, well, I have to say, I mean, the audience, especially, what is not a place for medical students versus students respiratory therapy students, because they're told that you have to publish a paper. A perspective piece. I mean, this has been my experience. Perspective is that we went to medicine gets you 6 points from an academic function. Major health system. If you do a media segment on that reaches tens of millions of people, you get 0, and you likely get judged. You likely get judged as a TV doc or whatever it is, and it's wrong. There is no reward structure in place to do this well, and we minimize the people that you want to have the voice and scale. We judge them.
Actually, that was keeping the new people down. That was one of the patriot. Dave actually said yesterday to me, he's sorry, Abel was looking at the show. He said, my boss was on TV, and you know what? One of my OK artists would go out and do these types of shows. That's what I'm talking about.
Yeah. No, it's.
Which, I mean,
But we need a reward structure. We need a reimbursement.
Okay, give it oil fans one more thing, and then we're gonna get Pooja on, and she's gonna tell oil fans one more thing. Okay.
Yeah. Don't
Our future secretary.
Well,
Human services, probably.
I just think I'm really hopeful for the future. I'm actually
Medical
hopeful
doctor.
for the next 11 months because I think we're seeing scale despite progress, especially we're at a digital health conference and there's a lot of people that are sharing some of the good news that we think that's going to happen administration. I think we should definitely. There's a lot of areas of concern. I think people are concerned.
Yeah.
All right. Come on the show when you're in
Okay.
charge.
Yeah. Don't go away again.
I'm gonna.
Okay, loyal fans.
Is this a cupcake with a
Yeah,
gonna-
because
I'll
a little
go into
bird
the-
told me it was
Here we go.
Melissa's
Come on.
birthday.
Listen, pay attention.
Listen.
Little bird.
Happy birthday to you. Happy birthday, dear Melissa. Happy birthday. There you go. So, loyal fans, almost done.
So much.
Melissa is still slinging shows at him, so get in touch with
Yeah.
her. Melissa, you want to say happy birthday to her?
She'll be here.
Yes. Nothing would make Melissa happier than you sending her $5,000.
Absolutely.
Or even 10.
I was gonna say 10.
Melissa, what do you want to tell our loyal fans? Honorary correspondent. Honorary correspondent. Yeah, he was
So, thank you. I appreciate that. I was excited to get Ben on the show.
Yeah, we like this guy.
You know,
What about you?
I'm getting afraid. So, it's all fun, and I'll be at Kim's, and interesting.
Yeah, she. This is an example of it.
So,
Very interesting person. I don't need her profile.
Melissa.
Melissa. Great. Thanks, everybody. See you next Friday or whatever.